move on to talk about some of the provider work streams now. Back office efficiency and optimal management, grandly titled, which is really around providing guidance to provider organisations and project management and resources to promote change management in terms of the way these services are provided to those organisations. Probably the most obvious example of this is the shared business services approach through the NHS, and around 30% of NHS trusts have used one of those one of the delivery modules around either finance, payroll, e-procurement, or and e-procurement. This has improved productivity, and the NHS potentially estimates it could save up to £250 million a year if it was adopted across all of the NHS. It has been implemented at multiple sites, but I suppose the question really is whether or not there is a general feeling that those level of savings could be made. In terms of procurement, the NHS is developing a best practice checklist to maximise local efficiency and is developing and implementing various procurement tools. One of the examples that is available at the moment is transport service for dialysis patients at Southend Hospital, where they have examined patient journeys and reconfigured them using mapping and regulated the use of taxis, resulting in savings of around £164,000 a year. No additional costs or investment are required, according to the evaluation on this, but it's only been implemented at one site so far, and there are no publications yet to assess that evidence. So again, a choice needs to be made there about whether that could be pursued. In terms of clinical support, the work stream here is really based around reconfiguration of pathology services, building on the Carter review, through application of lean processes, through the development of clinical leadership, and through improved IT services. One example here is around the reconfiguration of laboratory medicine services, breaking down the traditional lab discipline specific barriers with automated processing and testing of multiple laboratory disciplines on a single site. There have been some significant reductions in lab turnaround times, and again, there are no additional costs required for this. It's been implemented and replicated across the UK, and it's supported obviously by the Carter Review and a number of publications, so there's some strong evidence that works. In terms of productive care, the idea here is to support increased capacity and capability towards mental health wards, community services and operating theatres, and to support reductions in agency costs and better information on staff productivity. Again, NHS examples of this are still in development, but we'd be keen to hear of any in your local areas. And finally, on this work stream, or in terms of provider efficiency, the use of medicines and the procurement of medicines. And the aim here is to provide guidance on the efficient use of medicines in primary care and greater transparency on the costs of some treatments. An example here is the oral nutritional supplement prescribing review, which has allowed the training of healthcare professionals and care home staff to screen, appropriately treat and monitor patients at risk of malnutrition. Just briefly to outline what the system enabler work streams are around, these are designed to really help commissioners and providers implement the other QIP work streams. The primary care commissioning one is really around changes to the GP contract and the commissioning framework, and to support strategic health authorities to get the maximum value from locally negotiated contracts. And then the technology and digital vision work stream is around the implementation of technology to support the other work streams, supporting the development of regional and local IT strategies, and the issue of compatibility and interoperability of IT systems. John will talk about some of the examples of work that YHAC has done in this area in a short while. So we'll just briefly to outline what's happening at a local level in terms of monitoring of performance. The Public Health Observatory is producing a monthly QIP pack in the Yorkshire and Humber region, which gives some analysis for local providers and purchasers in terms of what their performance is. So as I say, commissioners will need to make decisions on the practical implementation of QIP initiatives and interventions that are evidence-based. And as I say, we have some significant experience of providing advice on the costs benefits of interventions. And I'll hand over now to John to talk about or to outline some of our experience in those areas.
Right. Thank you, Nick. We do occasionally come up with some more optimistic findings, because I know economics is often referred to as the dismal science, and particularly in recent months, the media have used that quite a lot. But the interesting areas for me, particularly in my work in technology assessment, are to look at the potential for win-win situations where new technology has been developed that actually helps the NHS to achieve its objectives, rather than give it a headache as to whether it should add the additional costs to its budget in order to get patient benefits. And one of these is has come up through the work of the National Technology Adoption Centre, which those of you who've worked with it will be aware is an agency which is tasked with taking innovations which have been proven to work and to look at the factors which are preventing them being adopted across the NHS. And we've been trying to help them with one of these, which is esophageal Doppler monitoring in the perioperative situation. And our estimates are that the savings could be between 160 and 370 million a year. Other people have produced more optimistic estimates, partly based on different assumptions about the number of operations for which this technique is actually relevant. What in fact it does, it's a minimally invasive probe which monitors the fluid levels in the bloodstream during the operation, and the clinical research has shown that if you maintain optimal blood flow and fluid volume, you get much better outcomes, at least a 15% reduction in average length of stay, reduction in readmission and reoperative rates as well, and also less time in critical care post-operatively in those patients who've been monitored in this way. So this is a really exciting development with relevance right across the NHS. Clearly there are costs of implementation in terms of getting the equipment and getting people trained to use it where they're not already using it at the moment. But the other interesting statistic in there is that the capacity released could actually accommodate another 140,000 major surgical procedures. It doesn't have to be seen just as cost saving. It could just up capacity to achieve targets for better service to patients, because obviously the savings from reduced bed days take some time to squeeze out of the system. Other work we've done with commissioners rather than providers has been largely focused on the community and how we can help them to provide services closer to patients' homes in a way which is more user-friendly for the patients, and which we hope at the same time releases resources to improve services elsewhere. Virtual wards are one example of that, and in one particular rural PCT, we showed that they could make over 3 million savings by adopting this model of provision of care rather than the mixture of unnecessary acute care and non-optimal primary care that was being offered at the time. Another interesting area that we're just starting to work in is the development of the new commissioning model with NHS Cambridgeshire, where we're looking at the baseline situation they find themselves in now, and then we're going to monitor how the PBC groups, which are becoming GP pilot consortia, how they actually change things over we hope it will be a 2-year study right up to the time when things have to go live. So, what lessons can we take from QIP in general, and what things do we need to bear in mind when we're looking at these optimistic figures that are produced from the national work streams? Well, first of all, not everything will work. As Nick has said, the level of evidence for these things is very variable. Some it's pretty good, some it is rudimentary. The benefits may not be evenly spread, because what works well in some particular geographies may not work well in others. And these global figures about savings are dependent on national take-up. They have been fairly crudely factored up by the number of trusts or the number of PCTs, number of departments likely to benefit from them.